control it in other countries very well. Over here, it's just whatever the traffic will bear. Like,
Well, let me say this about cost, and I remember, and you remember when President Obama, just days after his first inauguration, said we're going to work on healthcare, and job number one in healthcare is cost control. Well, that was the first thing that went out the window, because when he sat down with the major industry players, Big Pharma said, you will not interfere with our obscene profits. And he had to back up on that, so we lost control. The United States Congress has passed a law that says that the United States government cannot negotiate with the pharmaceutical companies. Everything else we negotiate. We take proposals, we take bids. If we're buying a new F-22 fighter jet, we're going to see who can deliver that. Of course, there's only 2 or 3 companies in the business. We're going to see who can deliver that at the lowest cost and the best benefits. We don't do that. We're not even at the point where we are scaling our reimbursement for medicine based on its effectiveness. We're not at that point. But to the point of the risk pool, what makes the property insurance business work, and it works for all, it serves us all, is the spread of risk. We got a lot of people in the risk pool, and I often say when people come in complaining about increasing rates, I say, well, no, you didn't have a loss, but your neighbor had a loss, and you're helping to pay for your neighbor's loss. Insurance is group protection, but it's also group punishment. We're all sharing the cost because we believe that the value proposition is worth paying for. But that's the only way to make this work is to have a huge pool, what I call the universal pool, every man, woman, and child in the system. Now, the rap on single payer and universal health care is this. People say, well, it would be monstrously expensive. Well, think too, you're no longer going to be paying private insurance premiums. Your employer is not going to be paying private insurance premiums. You're not going to be contributing to that premium. So that goes away. Also, what goes away is the cost of, as Carol says, the cherry picking. I happen to know health insurance underwriters are, for the most part, very sophisticated, usually well compensated people, because they're the ones that have the keys to the company vault. So they got to stiff arm the sick people and welcome in all those, the robust, the invincibles. That's their job. That's what they're paid for. Well, you eliminate that cost. Oh, what about the cost of the health insurance CEOs?
Oh, yeah.
Some of the best compensated people in the universe. That goes away. So when people talk about the cost of universal health insurance, I say, yeah, the price tag is big, but look at your savings. Look at what you're saving. And also look at all the economic inefficiency you're taking out of the system. Medicare operates on about a 3% overhead. That's great. That's wonderful compared to the private industry, 25% and up.
One of the other things that this Senate bill does is the ACA mandated that your insurance company had to spend 80% of your insurance premiums on health care. They could only have 20% of the insurance cost be for overhead and administrative costs and profit. Okay, so a lot of people actually got checks in the mail from their insurance companies as rebates because they had not met that. The insurance company had not met that guideline. This Senate bill takes that away. Insurance companies no longer have to do that. Okay. Now, there are insurance companies that are struggling to spend only 20% of your premiums on overhead, and Medicare and Medicaid both are running at a 3 to 4% overhead ratio. Talk to me about the efficiency of markets. Okay. The idea that if something is quasi-public or government funded or in some way connected to a government entity, that it is inherently wasteful or inherently inefficient or inherently ill-run is a dangerous and untrue myth. And you need to push back on it.
Could I add it? Just go ahead.
Oh, I was just gonna say, my name's Robin Dunn, and I've been talking to different folks. I'm running for alderman, and today, actually, I had someone talk to me about their concerns that Hardin is now a for-profit hospital. And I just was kind of wondering, what are you guys seeing around the area, that kind of, you know, for-profit versus non-profit like Vanderbilt?
Well,
Okay, I can
yeah.
tell you that there is solid research that shows that for-profit hospitals, for-profit dialysis centers, for-profit hospice, for-profit nursing homes across the board deliver inferior care. Period. Now, you can figure out why that might be, but it's very clear that when there's a profit involved, there is a tendency to reduce what you're providing, to reduce the acuity, the number of nurses that you have, and that immediately translates into worse care.
Okay, I'm gonna ask you a very just kind of off-the-wall question. So
I
think-
love off-the-wall
Okay, so
questions.
I know Hardin it used to be owned by either the city or the county, and at some point, I believe in the 80s, it was sold to a private group. Has any government body, either the city, a county, a state, I don't know, has anybody ever bought back their area hospital? Has that ever
Yeah.
happened before?
Houston County,
Houston County.
they buy it back.
Okay.
Yep, one of the things that we didn't talk about about this, what this bill is gonna do is, Tennessee last year was number 2 in the nation for, rural hospital closures. We had 11 rural hospitals closed last year. The number 1 state in the nation was Texas, and they had 12. Now, if you look at the population difference between Tennessee and Texas, Tennessee is by far, you know, there are things that you don't want to lead the country in, and closing of rural hospitals is one of them. Well, we are really good at it, okay? This Senate bill passes, these cuts to Medicaid happen, and you are going to see hospitals around this state, Franklin, Coffee, White County, and everywhere, they are going to be closing at an alarming rate. And you are going to have entire swaths of this state where people are going to have to drive 75, 80 miles to the nearest ER. Now, I don't know about you, both of my parents have had strokes. My father's had 4, my mother's had 1. The fact that they live almost literally in the backyard of their local hospital is the only reason that my mother is doing as well as she is today. I've had 5 heart attacks. You want to talk about the impact that having to wait for an ambulance for 40 minutes, then drive to an ER another 40, 50 minutes. Talk about the impact of what that's going to have on outcomes for people who have heart attacks, for people who have strokes, for people who are having seizures.
Or hemorrhaging when they're pregnant.
Hemorrhaging when they're pregnant. You want to talk about those things. That is a real life cost in lives saved, in employees being able to go back to work, and people and grandparents being around to help look after the grandbabies. You know, this is a real thing. This isn't, you know, some of us have been accused of engaging in hyperbole or in scary language or trying to frighten people. You know, okay, I had to drive about 100 miles to get here through a hailstorm and straight line winds, and so I'm fixing to get real with y'all about some stuff. Okay, this is the same group of people who pass, who champion these bills called Stand Your Ground bills, that are all about, you know, if you feel threatened by someone on your property, you can shoot them, you can kill them, and you're not going to be get prosecuted. You know, there's the case of you know, the young boy in Florida that was shot by someone. Okay, they have no problem understanding how someone could feel threatened that another individual might want to damage their personal property or steal their car, and that that person's reaction may be fatal to another person. Okay, now they plop this piece of legislation down on the table, which directly threatens my life, and they don't understand why we stand up and say, this is going to kill me. This is going to kill people. You are threatening my life. You are threatening the life of people I love. And when I stand up and say that, that's not hyperbole. If that makes you uncomfortable, if you don't like hearing that, you know, I ain't got any help for you.
Well, I'm going to actually elaborate on that a little bit. We have two co-founders of Physicians for a National Health Program whose names are Dr. David Himmelstein and Dr. Steffi Woolhandler. They are two of the smartest policy wonks I've ever met. And they just had a paper published in the Annals of Internal Medicine about a week and a half ago that did a meta-analysis. A meta-analysis is basically taking a bunch of previously published smaller studies and then pooling the data and making inferences about it. And what their meta-analysis revealed is that for every 786 people in this country who become uninsured, one will die every year. So we have 22 million people potentially losing their insurance. We have 28 million people who never got insurance with the ACA. So that equals 50 million people, and I did the math, and that works out to 62,500 preventable deaths every year. If we had 62,500 people dying in this country from car accidents, you know, self-inflicted gunshot wounds, HIV, or terrorism, we'd all be reading about it in the news. How many people in this room have heard that information on the news? None of you. 62,500 people every year dying.
It's something that I've been coming to a lot of things, and I agree with everything that everybody said. But something that's not been said, and I don't even know if there's been research done, is how many new jobs did the Affordable Care Act have? Because more people were insured, you need more technicians and all of these things. And how many jobs, closing hospitals, getting fewer people going to doctors, how many jobs are going to be lost? This kind of a political thing moves it away and shows that it's not just healthcare, which is of course the most important thing, but that nobody, has anybody heard statistics
I
about?
did-
Well,
yeah,
well,
yeah,
we'll
I
hear.
have, yeah,
The Senate
yeah.
bill cost Tennessee 28,000 jobs.
How many?
28,000 jobs.
The
The
Senate-
cost.
The Senate bill.
The Senate bill will cost
Yeah.
For those
28,000
healthcare jobs? Is
It's,
that what we're saying, or
Is
just?
that in for the country
across,
or
yeah,
Tennessee?
across the, it's just for Tennessee, it will
Oh.
cost, we will lose 28,000 jobs if this
28,000.
bill
But how many
passes.
jobs did we gain from the ACA? That's the
Well,
question.
That's
one of,
something I
well,
was thinking about
one of the
because
things,
we-
one of the things that we haven't talked about, you know, Medicaid is, Tennessee was one of the states that opted out of taking the free Medicaid expansion that we could have had. I don't know who, y'all will probably were not keyed into this, cause it wasn't relevant at the time, but Vanderbilt Medical Center, when the ACA was passed and was going through the, going through the court, issues that it had to go through, Vanderbilt Medical Center went on a huge hiring binge. They hired, I want to think it was 2,500, 3,000 new nurses, med techs, phlebotomists, radiology techs, doctors, administrators, blah, 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 in anticipation of the number of people that would be coming into the healthcare system through the expansion of coverage to the, not only the ACA, but the expansion of coverage to the Medicaid. Then the Tennessee State Legislature passed a law saying that our governor could not accept the Medicaid expansion, that it had to be a legislative process, and then our legislature turned that money down.
Twice.
And then
Twice.
but Vanderbilt Medical Center, after the Tennessee State Legislature turned that money down, then laid off all of those people.
Okay.
Okay? And this is, you know, it's,
There are other jobs involved here too.
That's what I was gonna.
yeah, I mean,
There's
there are other,
actually
yeah.
a very conservative group called, let's see, Business Leaders Transforming Healthcare. It's a group, it's a campaign that is part of the American Sustainable Business Council. And what this group of businessmen are preaching is that if we could take the cost of providing health insurance away from employers, get that off of their
Right.
responsibility list, they could hire more employees, they could grow their businesses, they could bring business back to the United States. I think it's Chevrolet who says $4,000 of the cost of I think it's Chevy, is the cost of providing health insurance for their employees. And so again, I'm really speaking to the conservative business case for a national health program.
There's an economic
It
argument
is a
there.
purely economic
Yeah.
argument. And I'm the one, I'm the doctor, you know, I should be saying healthcare is a human right and saving lives and all this stuff, and I can make that argument, but I'm also a really fiscally conservative, penny pinching human being. It's just the way I am. And I don't like to waste money. And what we're doing now is a huge waste of money.
It is.
In our area, I don't know about other areas, we have so much part-time employees. And I'm talking part-time, 7 to 12 years type of employment going on. And that is basically due to insurance and these kind of employees' costs. If the companies didn't, they could hire the people
Exactly.
full-time. And you know, when you work part-time, what does this do? You can't buy a new car, you can't buy a house. Henceforth, nobody's buying a car. Everybody's renting houses, if you've noticed,
Right.
for rent everywhere, because they cannot build the kind of credit and stability they need working part-time. And it's a very transient thing. Well, if I can find something better, I'll go.
And people get tied to jobs that they hate
Yes.
That's
for
exactly
years.
right.
I have friends
In
who
Canada.
worked in jobs that they hate, they loathe them, And the ACA, I have friends who that allowed them finally to leave these miserable, often part-time jobs and go start a business and hire people and contribute in our community, in our local economy, in a way that they never had been able to do before. And so it's a tremendous, I mean, I'm all about the moral argument, and I love what you said about that. It is a moral document, but there's an economic argument that we can make too.
And, yeah, I'll just say,
Yeah.
usually the moral argument and the economic argument, actually, you know,
Yeah.
They're
when
reinforcing.
you
Yeah.
do the right thing, it's usually the right thing.
Yeah.
Economically,
Yeah.
morally, socially.
Let me just say this on this economic issue, and I know we're out of time, but back many years ago, I was on the Warren County Commission and chairing the Education Committee, and we had this healthcare crisis then of our employees, and the school system is the third largest employer in our county. That's true in a lot of rural counties. One of your top employers, and my position was we needed to get the Warren County Commission to step up and put more money into employee health benefits, including teachers and teachers' aides and bus drivers and all that. And I asked the director of schools at the time, Dr. Jerry Hale, I said, if you would give me, take just some representative payroll sheets, blank out the name, I don't need to know any names, so I can see what the health care cost impact is on these employees. We had a school secretary. Now, school secretaries are sometimes overlooked, but they're the most important people. Church secretaries and school secretaries, the world doesn't work without them. But she was married, had a family. Her husband was a self-employed tradesman. She was working because just to provide health insurance for her family. And when I looked at the take-home pay for that pay period, she got $12 and some coins. That was her take-home pay. It was every bit consumed by health insurance.
One of the questions that I hear, or one of the reservations that I hear a lot of times when people like to put this moniker of socialized medicine, you know, on universal health care, they will point to other countries and say, well, these other countries have socialized medicine or have universal coverage, but the wait times are so long. I don't really know how to answer that.
I'd love to answer that.
Please.
Yes. In fact, Canada does have a waiting time. And that waiting time is for elective procedures only. If you're having a heart attack, you are not going to wait, okay? And in Canada, you can go on a website and find out exactly what the waiting time is in this city, in that city, and in that city. And if it's shorter and you're willing to drive to another city, you can reduce your waiting time. In addition to that, Canada has reducing the waiting time as a national effort to fix, okay? And the final point is, we spend twice as much money as per capita as Canada does in the United States. They cover everybody. We leave, right now, 28 million uninsured, and pretty soon it's gonna be 50 million.
We
Okay?
spend.
So yes, there is an issue, and when we say that our wait time is lower, this is the other thing, that it's actually a spurious comparison. They're not comparing apples and apples. Every other country that says they have a waiting list that's longer than the United States is the wait for every single person in the country who needs a knee replacement, for example, on average, how long they wait. In the United States, when we say our waiting list is a couple of weeks, it's a couple of weeks for the people who can get in the queue.
That's what I said.
If we put in the people who will wait until they die, the wait list for a knee replacement in the United States would be on the average of years, if not tens of years.
Thank you.
After last question.
Okay, so one of the conservative oral arguments I hear is about to reduce the federal deficit. And so, as a millennial, I'm incredibly concerned about the debt of this country because unfortunately that falls on me and my generation. So, I mean, the projected growth of healthcare costs in this country, it's unsustainable. So, you know, Medicare for all is great, but in theory, I mean, these programs might become financially insolvent in 20, 30 years when there's too many people taking out, not enough people putting in. So I'm just concerned, like, what would be an argument that you would say, for people would say, well, we need to reduce the federal deficit, and that might encompass Medicare for all?
I hate to, I mean, again, this is my area of expertise, so. If we had enacted Medicare for all in 1971, when Canada went, they began it in the 50s, but they were the whole country was on board with it in 1971. If we had done the same thing in 1971, what we did in 1971, it was Richard Nixon passed the HMO Act. And the HMO Act actually is premised on the idea that market forces will reduce the cost of health care. What happened in the United States? And Canada and the United States were lockstep until 71. And then in 71, it went like this, okay? The United States cost of health care doubled and doubled and doubled, and Canada's went up a little bit. So all that money in here is the money you're worried about, and you have every right to be worried about it. I actually don't think we can afford to continue on the trajectory we're on. I don't know how many years it will take before we can bring that cost down. But a national health program will have that as its goal always and forever, to maximize care and keep costs in check. And it's actually possible, because you had mentioned all the waste, fraud, and abuse on the delivery side of healthcare. I'm not going to promise that passing a single-payer healthcare plan in this country is going to fix that problem overnight, but we're never going to be able to address that problem until we address the problem of getting everybody in the same risk pool.
What I really meant by it was that when you're using these arguments with your Congress people and talking to them, tell them they have got to do something about controlling the cost. We want universal health care, but if they keep charging like $300,000 for a cancer treatment, that's obscene.
Right.
I mean, she needs that treatment. It should not cost that
Right.
much.
And
It
well,
does not cost that much in the rest of the world.
The thing about the way our system, the way we deliver health care in this country, all of the incentive, because it's a profit-driven entity, all of the incentives, if you remember your basic economics, supply and demand, the supply of something and the demand of something comes to meet, and that's how the market comes to a price. Okay, in healthcare, all of the incentives are on the supply side. All of the incentives are on if there is a newfangled cardiac imaging machine that the local hospital has just bought, then more people start getting sent to the cardiac center to get that imaging, whether they may absolutely need it or not. Whether or not if you need the newfangled MRI technique, but your local hospital doesn't have it, you get whatever the hospital has. All of the incentive is on the supply side. Okay, there's a drug, it's been out forever, a shot that most chemotherapy patients get after every chemo treatment. It's called Neulasta. There's one called Neulasta and one called Procrit. One's to help your white blood cells, one's to help your red blood cells. When I was first diagnosed 6 years ago, I would have my chemotherapy treatment on Thursday, and then on Friday morning I'd have to get up and somebody would have to drive me back to the hospital so I could get my Procrit or my Neulasta shot. Okay. Yes, it was inconvenient. Okay, but that's what you do. Okay. Then the company that manufactures those drugs, they came up with a newfangled way to deliver this drug, and it's essentially a patch with a little reservoir of the drug you put on the patient the day they have the chemo, and they go home. They don't have to come back for the next thing, and the drug is slowly released into the system. Well, that's great. It eliminates that trip that you had to take the next day. Does anyone want to guess how much that little patch costs? It's $8,000. One is $8,000.
And it's advertised on the evening news.
And it's advertised on the evening news. It costs $8,000. That little shot that I had to go and take the next day, I believe was about $40. Okay, now I am all for medical innovation. Medical innovation has saved my life. All the incentives are on the supply side. Okay.
I think we'll go ahead and stop there.
Yeah.
I hope that you learned a lot. Yes. And I hope that you will leave with a better understanding of our healthcare system and threats to it, as well as the health and well-being of our country and its citizens. It could be so much better. I hope that you will take the opportunity to take some materials and contact our members of Congress, our elected officials. Know that you know more than they do. I really believe that. Also, Afton has some postcards that any little thing that you learned tonight, and you want to just jot that down. And if you do them before you leave, Afton will go and take them to the senators. Is that right? And you can say,
Yeah.
Thank you.
Yeah, I'm delivering some stuff to the senators tomorrow as well. I can
All right,
take.
so Kelly will take them to the senators.
I hope that everybody is signed in. I hope that you won't mind some follow-up phone calls to see how you're doing, and
I will,
if something else comes up, or where we can go from here.
If anyone has a church group that they would like to set up some kind of a meeting, or you would like for me to come talk about healthcare or Moral Movement Tennessee, I am more than happy to talk to any group. I'll come to your Rotary luncheon. I'll come to your Sunday school class, to your senior citizen center, League of Women Voters, whatever you like, and I will talk about healthcare and Moral Movement Tennessee to anyone. My own